Good morning. Welcome to the M3 Mobilizing Medical Missions pre-conference workshop. I'm Nicholas Comninellis, President and Dean at the Institute for International Medicine. And this is an official continuing medical education event. We are holding this in compliance with the Accreditation Council for Medical Education. And if you are here for continuing medical education, there will be a certificate that you need to fill out. It's an online link that I will share with you later in the day. If you are not a physician and you would like a certificate of attendance, you can also fill out the same evaluation that everyone else does, and you too will receive a certificate for being here. All of the presentations that we're doing today are available for you to download. Here's the QR code. You can scan it now if you wish. There's also a link, and it is on your agenda. So for the next 30 days, you'll be able to download all of the PowerPoints that we're going to use today, which is really important because we are going to cover a lot of information that is quite relevant to the care of people across cultures and in low-resource settings. To launch into this, I want to start at 50,000 feet and provide some perspective on the world of tropical medicine before we get into the nitty-gritty. And I want to start by asking you, who is the most famous person in medical missions? Who is the biggest name on behalf of healthcare for the poor? Jesus. Who is the person that inspires you? Absolutely, Jesus, the King of Kings and the Lord of Lords. If you ask that question to your great-grandparents, they might say Albert Schweitzer. He was the famous musician, philosopher in Germany who went to a conference rather like this and heard about the physical needs in Africa. Changed his career completely. Went to medical school, moved to Gabon, where he worked for the next 50 years. I grew up with Tom Dooley, the U.S. physician who was in charge of refugee care at the outset of the Vietnam War. His book, Deliver Us from Evil, was the biggest single motivator to draw me into this field. More recently, there have been people like Paul Farmer, but what do you know about David Livingstone? So we think of Livingstone as the great explorer, the first person to cross the continent of Africa, the one who discovered the origins of the Nile River. But his life was actually way more interesting than that. Livingstone was born in abject poverty. He started working factories as a child. His father homeschooled him, and he got into the University of Glasgow, where he met inspiring people like you. He got this vision for the world. And as a young man, he moved to what is today South Africa, where he was immediately mauled by a lion that crushed his right shoulder, left him with a brachial plexus injury, and his right arm hung limp at his side his entire life. But that didn't stop him. In his autobiography, he writes that the happiest years were his first 10 years in Africa. He was raising his family. He was pastoring a church. He was winning people to Jesus. He was caring for people who were poor and sick. And it's only then that he began to travel. Now, unlike the explorers of the day, he did not carry guns. He did not have an army accompany him. It was normally him, the only Caucasian, and his African guides. And so everywhere he went, he was welcomed. And everywhere he went, he shared the message of Christ, the hope of salvation. So he was welcomed as he went. And he also wrote letters that were published in Western Europe and in North America describing African people as human, describing their emotions and their dreams. It was a radical concept in the mid-1800s. And it essentially laid the foundation for the elimination of slavery in the British Empire, because he was describing the humanity of African people. He was one of the most influential people of the 1800s, and he himself died of malaria and dysentery. Now here we are, almost 200 years later, in the internet age, and what are people dying of? Malaria and dysentery, exactly. Now, when I say poverty, what do I mean? You know, you look at a map of the world like this and you see nations in red and you say those are nations of poverty. What do we mean by poverty? Somebody raise your hand and tell me, what is poverty? Lack of means. Lack of needs. What else? How else would you describe it?
Not being able to meet the basic necessities of life.
Not being able to meet the basic necessities of life. Sometimes poverty is described as hopelessness or lack of role models. But usually we define poverty as a number. You know, living on less than $3 a day or less than $2.50 per day. Because it's miserable and we can identify who are those communities. Now there are some places today, Friday, February 16, where poverty is growing enormously. Where is poverty shooting up? Raise your hand and say the name of a country. Haiti, US, Canada, Belize, Nicaragua, Palestine. Wherever there is civil conflict going on, poverty is increasing dramatically. Now, you've been following the news about what's going on in Palestine. Similar phenomenon going on in South Sudan right now, in Somalia, in Yemen, wherever there is civil conflict. Also remember that every nation of wealth has got pockets of poverty. I live in Kansas City. You know, we have got the poverty areas of the town. And so wherever you might be serving, even if it is a nation of wealth, there will probably be low-income people. And everything that we're talking about today may apply to those individuals as well. Now, for the sake of perspective, I want to talk about an important health statistic. Did you know that women live longer than men? Have you noticed? And why is this? What is it about men? Now, do you see women doing stuff like this? They're way too smart. Now, you know, men, we've got this, we'll figure it out. Give us some duct tape and give us some super glue, and it can start at a really young age. So it's been going on a long time. Women living longer than men. This one's rather shocking. What are they thinking? My goodness. Well, the statistic that I want to share with you is called the DALY. That is the Disability Adjusted Life Year Lost. Now, if that shot over your head, let me explain. If an 80-year-old person dies of pneumonia, how many people died? One person died. If an 8-day-old infant dies of pneumonia, how many people died? One person died. But the gravity of those deaths is vastly different. And so what the DALY does is it takes into account not only what kills someone, but how old were they when they died. And so if you look at the world's lowest income countries, what do you suppose are the leading causes of life years lost? What is it that is reducing the life years? Tell me some diseases. Malaria? Preterm birth? Measles? Cholera? TB? Now this is important because this kind of data gives us perspective about what are the biggest problems. Now, our resources are always limited. And so for efficiency, we want to apply our resources toward the biggest causes of life years lost. And these are the numbers. So number one cause is pneumonia. Now, in the United States, we always think of pneumonia as the old person's friend, the old person's disease. In the developing world, in the world's 50 poorest countries, it is the children that die of pneumonia most frequently. And then towards the bottom of the list, you see things like road traffic injuries and hypertension and diabetes, increasing problems. There are also statistics that are useful. So if we look at all low-income countries, life expectancy is about 59. If we compare that with life expectancy in high-income countries, it's almost 80 years old. They're on the bottom row. And then some of the worst health statistics are particular nations that are listed here, where not only is life expectancy low, but child mortality is very high, and the amount of money spent on health care is proportionately low. So this helps us to measure the gravity of health problems, of health status within these countries. Now I'm going to show you some images quickly, and I want you to tell me, what do you see? So here's poverty. Here's tuberculosis, HIV, tuberculosis, malaria, malnutrition, malaria, tuberculosis, HIV, poverty. What's going on here? Same places, lots of overlap. So much of Southern Asia and Southern Africa have this overlap of both poverty and disease. Now you notice that malnutrition was not listed on that chart of causes of life years lost. Why not? They die from complications. Yeah, normally we do not list malnutrition as a cause of death. It is a predisposing risk factor. So you can imagine if this child develops pneumonia, he's not going to do well in comparison to a well-nourished child. So actually the data shows that over half of childhood deaths in the world's 50 poorest countries have malnutrition as a significant risk factor. Health status, economic status, very, very closely connected. When you think of people, of children like these, I shot this photo in southern China, why would they be at risk for an infectious disease? Why do you suppose?
No access to care.
No access to medical care, yes.
A lot of people in the same room.
A lot of people in the same room. Contagious diseases, depressed immune system. No hand washing, sanitation, probably access to safe drinking water. Understanding of the cause and effect of disease. Where are their parents? And are their parents prepared to help protect them? Lack of immunizations, probably it's not going to be so available for these people. So here's a question for you. 70% of childhood deaths in low-income countries are due to which one? I hear C, I hear D. Who's interested in pediatrics in low-income countries? All right, so you need to know this. 70% of childhood deaths are due to an infectious disease. And what are the 5 leading infectious killers of children? We've talked about all of them so far this morning. Tuberculosis, malaria, used to be HIV, but not so much anymore, thank goodness. Dysentery, pneumonia. All right, so pneumonia, dysentery, malaria, tuberculosis, and then the last one is vaccine-preventable diseases, mainly measles. And so if you know those 5 diseases, that's going to be the majority of the pediatric acute conditions that you will probably encounter. Now, there's a close connection between economic status and health status. One of the most fascinating studies was done in India where they measured people's hemoglobins compared to their income. And they found that if they had a low hemoglobin, 5 say, they made $5 per week. And if they had a hemoglobin of 15, a normal hemoglobin, they were making $50 a week. Now, why is that? Energy. How much work can you do with a hemoglobin of 5? Well, then the intervention was to treat these people with low hemoglobins, and as their hemoglobin rose, guess what? So did their income. Exactly. And so improved health increases their income ability. And then the other is also true. Improving income also increases their health. How is that? How is it that a growing economy grows people's physical health? They're eating better. Access to health care. Improved mental health. Some of them might go to school, get better jobs, increase their income, be able to afford a better house, safer drinking water, better road safety, reduced industrial accidents. Which brings me to, what do we mean by health? Now, when I was a medical student at the University of Missouri, my professor said, if you do a history and a physical exam on that person and you find nothing wrong, guess what? They're healthy. Right? Wrong. Okay, so which brings us to this WHO definition, the complete state of physical, emotional, and social well-being, not just the absence of disease. Now that sounds rather lofty, but it's really true that health status is not independent of everything else in a society. So where you have functioning government, functioning schools, functioning industry, health is usually pretty good. And then the opposite is also true. And so my first point is that if we want to reduce the diseases of poverty, we need to reduce the poverty. Now, some of you have already been involved in this. What have you seen going on in developing nations to lift people out of poverty? Microfinance. Literacy programs. Clean water. Small loans, especially to women, have proven to be very effective in increasing people's income. One of you mentioned literacy. So this is a fascinating chart that correlates literacy among young mothers and the risk of their children dying. And what we're seeing here is that on the lower right corner, young mothers who are highly literate have a very low risk of their children dying. And in the upper left corner, illiterate young mothers have a high risk of their children dying. Why is that? Lack of knowledge. Lack of income. Age of first fertility. Very young mothers. So a lot of it has to do with income and social power. The literate woman has more control over her body in general, has more income generating ability, translating into better health for their children. Who's familiar with Heifer International? Heifer is headquartered in Little Rock, and their model is animal husbandry. So they'll give a family a goat, they'll show them how to reproduce the goat, sell the goat, butcher the goat, milk the goat, use the animal to create income for the family. At the beginning of my career, I worked at the charity hospital in Shanghai, China. Inner city Shanghai, mostly what we took care of was tuberculosis and schistosomiasis and rheumatic fever, diseases highly connected with poverty. Since that time, as poverty has decreased in China, guess what? Along with this economic growth, also, life expectancy has been growing in China. And anymore, we don't see those diseases at Shanghai Charity Hospital. Physical health and economic growth are inextricably linked. Stronger economic conditions foster greater health through all of these mechanisms, except which one? Which one doesn't fit? Exactly, increased fertility. So as economies grow, what happens to fertility? It goes down, and why is that? Too busy working or going to school or pursuing other things, delaying. And of course, as they have fewer children, those children are usually healthier, and the women themselves are usually healthier, as a result. So, lift people out of poverty. The second point is we must advocate to end military conflict. Now, that is not a political statement, that is a public health statement. Who is it that dies in modern wars? Primarily women and children. The ratio is about 9-to-1. Civilians versus combatants. Now, this is the same chart I showed you at the beginning, only now I've highlighted in red nations that are at war or recently at war, which have the world's very worst health statistics. It's very hard to collect health data with a war going on. But the British Medical Journal managed to do it in eastern Congo and describes of an excess mortality of 2.5 million, only 350,000 were because of direct violence. Most died from malnutrition and infectious diseases. Now, from the news this week of what's going on in Gaza, it appears, that half of those 25,000 something who have died are children. If that doesn't tear at our souls. Now, I witnessed this later in my career working in Angola, and at that time, we saw a lot of children and women and very few men. Where were the men? They were fighting or they were already dead. And so this was a period of time in which there were no functioning schools, money was worthless, there was no communication, there were more landmines per capita than any other nation in the world. Now, occasionally we would see someone with a gunshot wound or a landmine injury, but in reality, those people usually died before they made it. And instead, we saw a lot of these diseases that should not exist. Measles vaccine is what, 95% effective? Malaria treatment is usually effective. We were not set up to do hunger relief. We were a medical care facility. And yet one year I walked out on the balcony and there were all of these people. And if you look carefully, many of them are holding a tin can. And they said to me, "Oh, doutor, por favor, estou com muito fome. Não tenho nenhuma comida na minha casa. Ajuda-me. Help, we don't have any food at home. Give us something." And so we went inside and we got out a vat and we put in some porridge and a little cabbage and brought the food out. And everybody leapt to their feet and they rushed forward with their can to get some food. And in the chaos, the vat spilled over. And everyone went away hungry. Well, the next morning, I came back and they were there again, and they all had their can and they wanted food. And I thought, what am I going to do? And at that moment, I remember the account of Christ feeding the 5,000. And if you read it carefully, it says he had them sit down in groups of 20s and 50s. And I think I know why. I think it was for crowd control. And so I went out ahead of time and I had them get in little groups and we brought the food out again and they came up one group at a time and everybody got food. And then it began to rain and the crops began to grow and Angola got a peace accord. And now they're so busy making money, they don't have time to fight. And along with this, of course, we're seeing less malaria, less measles, less of those diseases during wartime. Number 3, finally, if we really want to fight diseases connected with poverty, there are certain effective health interventions that you and I, as health leaders, need to be aware of. Now, hearken back to our priorities. Same chart. Pneumonia, dysentery, 2 leading causes of death. What are the organisms that cause pneumonia in the developing world? If you were going to treat these people with pneumonia, you need to know what causes it so you can give them the right antibiotic or whatever medication you think is appropriate. Pneumococcal pneumonia, exactly. There is nothing exotic about pneumonia, all right? It's the same causes in Houston as there is anywhere else in the world. So everything you know about pneumonia is applicable. Now, put on your public hat a second, your public health hat, and ask yourself, what would you do about the worldwide epidemic of pneumonia? What can we do? Vaccination. What else? Hand washing. Nutrition. Education. Yeah, income, sanitation. Now, let's dwell on vaccinations. Almost all of you have had 3 or 4 different pneumonia vaccines. What have you had? You've had pneumococcal vaccine. You've had Haemophilus influenza vaccine. COVID vaccine, influenza vaccine. Now, these vaccines are not available in most developing countries. It's because they're expensive. Some of them need to be given every year, so the logistics are challenging. So what's the leading intervention for pneumococcal pneumonia or pneumonia in general? It's early recognition and treatment. So if you were educating young parents about signs of pneumonia in their children, what would you tell them? Fever, cough, shortness of breath, malaise, breathing rapidly. And so if your child has any of these signs, you must get them treated, right? Who's going to treat them? So in an effort to provide some level of medical care, many developing nations make use of community health workers, or health promoters, or promotores de salud, people with a high school education that do a 6-month course in basic paramedic and are deployed to serve these communities. We normally expect community health workers to be able to do all of these things except what? Pursue higher education. Now, we want them to be prepared. We want them to have skills. We want to reinforce those skills periodically. But we found that if you send them to a higher level of education, what will they do? They'll never come back. That's right. And so selecting the people to be trained to become community health workers is critical, and encouraging them to stay on in that role serving their communities. Diarrheal disease, similar to pneumonia, mostly kills children. What are we doing about the epidemic of diarrheal disease around the globe? What are some interventions you know of? Clean water, sanitation. Can I have your water bottle? So one of the most effective ways to make water safe to drink is to take a clear plastic bottle like this with contaminated water and set it in the sun. 6 hours of UV radiation, it may still look brown, but it'll be safe to drink. It doesn't require firewood, doesn't require any chemical substances that you might not have. There's a lot of ways to make water safe to drink. When I lived in Angola, I would take well water, put it in the filter it, and then put in 1 milliliter per gallon of water of Clorox bleach, chlorinated water. Tastes a little funny, but no one got sick. So there's a lot of ways to make water safe to drink. And then along with that, we have to have a way of disposing of the waste effectively. Interventions against diarrhea. So, high priority, pneumonia, high priority, diarrhea. What about those neglected tropical diseases? Who has heard that phrase before? Neglected tropical disease. You've heard about that. No, very few of you. Well, now you have. So if you look at the literature, you'll find this mentioned a lot. So it's a group of viral, parasitic, bacterial diseases that are really prevalent around the globe, for which we have got adequate treatment, but these people are just neglected. Now, what diseases come to mind? Leprosy, yes, leprosy. What are some of these other classic diseases that are neglected? Schistosomiasis, onchocerciasis, leptospirosis, yaws, guinea worm. Now, we're going to touch on some of these today. There are more than you can imagine, but we're going to hit the high priority ones. And depending on the community that you serve, you may actually have these diseases and you need to access the resources available to treat them. The first level, of course, is just basic sanitation, basic nutrition, housing, economic development, education, all of these elements, and then pair that with modern diagnostics and therapeutics that are available against those particular diseases. You mentioned leprosy. Is leprosy still a problem around the world today? It is. Exactly. Almost 250,000 people are diagnosed with leprosy each year. Mostly in Southeast Asia, but in other places around the globe as well. In Angola, during my tenure, we had leprosy villages. People would be diagnosed, they would be isolated from the community. These are some children at a leprosy village near Kalukim Hospital. I want to introduce my colleague, Steve Foster. Steve, would you please stand a moment? Steve Foster was my mentor on arrival in Angola. He walked me through my first solo cesarean section and how to diagnose leprosy, and we will hear from Steve a couple of times later this morning. So, give me some salient facts. Give me some pearls about leprosy. What do you know about the disease?
It's disfiguring.
Disfiguring. Bacterial. Treatable. Causes anesthesia. A social disease. Takes a long time to grow. It has a lot in common with tuberculosis, actually, the organism that causes the disease. People who are diagnosed with leprosy were usually exposed years ago. It takes 3, 5, 10 years from exposure until they actually manifest the disease itself. There are different classifications of leprosy. So if you open up a review article on leprosy, you'll probably see 2 or 3 different classifications of leprosy. This is the one I prefer. It's the simplest one. There's paucibacillary, and that is leprosy that is in low concentration in the body. And it usually causes the skin to be anesthetic. It causes nerve palsies. And then there's multibacillary. This is the disfiguring disease that affects mainly the nose and the mouth and the sinuses. And if you do a biopsy, you see lots of organisms in that kind of person. So what do you suppose, which classification could this possibly be? It's on the extremity, it's well demarcated, and it's anesthetic. You touch it and they can't feel it. Paucibacillary, that's right. Paucibacillary, which is the more common kind. Anesthetic macules are usually the first clue. What's this? This is a person who has flexion contractions of their forearms. What kind of leprosy is that? It's also paucibacillary. It's the low concentration. It affects the ulnar nerve and leads to these flexion contractures. Also more common than this kind. So this is what kind of leprosy? Multibacillary, all right, which tends to affect parts of the body that have low temperature. So nares, anterior chamber of the eyes, mouth, sinuses. Fortunately, not as common, but far more socially disfiguring. How would you make the diagnosis? If you saw somebody like this, how could you confirm that this is or is not leprosy? Ideally, what you would do is you would have a biopsy. And so typically what we would do is we would make a small incision and spread the fluid, the subcutaneous fluid, on a slide, and we would stain it with acid fast to see if we can find the bacilla, like these. It looks similar to an acid fast test we would do for tuberculosis. Now, there are some other tests for leprosy. There's a skin test, there's a PCR test, but this is really the standard. If you can get some fluid or some tissue from one of those lesions and actually identify the organism. Which one of these is false regarding leprosy? One statement is false. It is D, that's right. Most people with leprosy have been living with a leper. It's their children, it's their in-laws, it's years of exposure before they develop the disease. Now, how are we going to treat it? You've made the diagnosis of leprosy. What are you going to do? Quarantine. What's the role of quarantine? Not nearly as much anymore because we have effective drugs. And so all of those leprosy colonies, leprosy villages, essentially not necessary because we've got the effective medication treatment. So for paucibacillary, it's 2 drugs for 6 months. For multibacillary, it's 3 drugs for a year. Often these people need some serious PTOT. You saw those hand contractures. That can be improved with PTOT. And so you need to find someone who has got that kind of skill set in order to help these people. And then the control of the disease is all about identifying people who have the disease and making sure that they're treated so that it's not transmitted to their family members. So in summary, if we want to address the diseases of poverty, we have to address the poverty. If we want to address the diseases of poverty, we have to address the military conflict. And we need to be aware of specifically effective prevention and treatment methodologies like we just touched on. You're here because you have a vision for the world. You have a call of God. You want to dedicate your skills on behalf of the world's most forgotten people. David Livingstone would be very proud of you. And so am I.